Conservative dentistry? Lek for Dr. Lin's. Classification of cavity. 1. According to tooth surface involvement. Simple cavity. Cavity involve only one surface of the tooth X. Occlusal cavity. OCLI. Compound cavity. Cavity that involve two surfaces X. Mesoocclusal. MO. Cli. Complex cavity. Cavity involve three or more surfaces. 2. According to site involved. Site 1. Pits, fissure and enamel defects on occlusal surfaces of posterior or other. Smooth surfaces. Site 2. Proximal enamel in relation to areas in contact with adjacent teeth. Site 3. The cervical 1/3 of the crown, or following gingival recession and the exposed root surface. 3. According to G.V. Black, Cli restorations. These restorations are used in CLI lesions. The following surfaces are involved. Occlusal pits and fissures of premolars and molars Fig 1a. Facial and lingual pits and fissures of mandibular molars Fig 1b. Palatal pits of maxillary incisors, most frequently in the pit near the cingulum. 1. Made with Zato PDF reader and editor. Conservative dentistry? ABC. Figure 1. CLI. CL2 restorations is the extension of Cli restoration into the proximal surfaces of premolars and molars. The following surfaces are involved. 2. Surface restoration of posterior teeth Fig 2a. 3. Surface restoration of posterior teeth Fig 2b. 4. Surface or more restoration of posterior teeth Fig 2c. ABC. Figure 2. CL2. 2. Made with Zato PDF reader and editor. Conservative dentistry? Cli affects the interproximal surface of incisors and canines Fig 3. Fig 3. CL3. Cliv involves a larger surface area, including the incisal edges and interproximal surface of incisors and canine Fig 4. Figure 4. CLIV. CLV. Gingival third of the facial or lingual surfaces of any tooth. Root of a tooth near the cemento-enamel junction Fig 5. Figure 5. CLV. 3. Made with Zato PDF reader and editor. Conservative dentistry? CLIV. Incisal edge of anterior teeth or on cusp tip of posterior teeth. Objectives of cavity preparation. 1. To remove diseased tissue as necessary, and at the same time provides the protection to the pulp. 2. To locate the margins of the restoration as conservative as possible. 3. To ensure the cavity form It should not be under the force of mastication of the tooth. 4. To allow the functional placement of the restorative material. Steps in the cavity preparation, given by G.V. Black. Obtain outline form. Obtain resistance form. Obtain retention form. Obtain convenience form. Removal of remaining carious dentin. Finishing of enamel walls and margins. Performing the toilet of the cavity. Class 1 cavity. 1. Outline form is the shape of the cavity which the cavisurface line angle of the cavity assumes after preparation. Access. Gain initial access via the most carious part of the tooth. Margins should be placed on sound tooth structures, in CLI-occlusal fissures, and at least that in the developmental grooves have been included in the preparation even hen caries has not extended throughout. 4. Made with Zato PDF reader and editor. Conservative dentistry? The fissure because it has been noted that carious dentin, although not evident, visually or radiographically seen at the base of fissures, there is a strong evidence that carious dentin may be present at the base of a sealed fissure. Extension for prevention. 2. Retention form is the shape of the cavity that permits the restoration to resist displacement through the tipping or lifting force. To provide retention, the cavity have the following. Opposing walls should be parallel to each other or converge occlusally 50. This convergence done on buccal and lingual wall Fig. 7. The floor of the cavity should be flat to prevent restoration movement. Outline form should be small as possible to prevent displacing force on it. 3. Resistance form is the shape of the cavity that enables both the tooth and restoration to withstand occlusal forces without fracture, and this includes 1. Prevention of fracture of the tooth. The facial-lingual width of the preparation should not exceed 1/4 intercuspal. Distance Fig. 6. 5. Made with Zato PDF reader and editor. Conservative dentistry. Cavosurface line angle should be 900. 1100. Fig. 6. Resistance means of CLI removal of unsupported enamel by making the margin 900. -1100 because less than 900 the tooth is more subjected to fracture. Smooth pulpal floor to prevent stress concentration area. Mesial and distal walls of the cavity should be parallel and slightly diverge. Occlusally to be within the enamel rod direction and prevent any unsupported enamel at the marginal ridge. All internal line angle should be rounded to prevent stress concentration area. Fasciolingual walls converge occlusally, rounded. Internal line angle. Figure 7. 6. Made with Zato PDF Reader and Editor. Conservative dentistry? Preventing fracture of restoration? The margins or cavus surface line angle should be 900. Negative 1100. If more than this, lead to fracture of restoration. Faciolingual width should be 1/4 intercuspal distance, because large surface area exposed to more force and fracture occur. Occlusal amalgam should have thickness of 1.52.0 mm to resist fracture. During function, the pulpal floor should be smooth to prevent concentration area on restoration. 4. Convenience form is the shape of the cavity that allows an adequate observation, accessibility. This achieved by giving good depth, 1.52 mm, and width, 1/4 intercuspal. Distance. 5. Removal of remaining caries. Deep dentinal caries can be removed by using spoon excavator or a large round burr with slow speed hand piece. 6. Finish enamel walls. Involve making the wall smooth and removing of unsupported enamel. 7. Clean the preparation. Removal of all debris by washing the cavity and drying it. 7. CL to amalgam restoration. Preparations involving the proximal surfaces of posterior teeth are termed Class 2. The following surfaces are involved. 2 surface cavity for posterior teeth Fig 1a. 3 surface cavity for posterior teeth Fig 1b. 4 surface or more cavity for posterior teeth Fig 1c. ABC Fig 1a. 2 surface cavity B. 3 surface cavity C. 4 surface cavity. Step 1. Outline form and initial depth. Establishing the outline form means placing the preparation margins in the positions they will occupy in the final preparation. The typical features of establishing proper outline form and initial depth are width of the faciolingual walls of the cavity should be ICD, preserving marginal ridge strength, 2 mm thickness marginal ridge. The depth of the preparation into dentin should be 1.52 millimeters. 1. The extent of the caries lesion affects the outline form of the proposed tooth preparation because the objective is to extend to sound tooth structure. Also, ideal outline includes pits and fissures, even if it's sound, to prevent them from caries in the future. Extension for prevention. Step 2. Resistance form may be defined as the shape of the cavity that prevent fracture of the remaining tooth structure and the restoration. This includes factors prevent fracture of the tooth. The faciolingual width of the preparation should not exceed ICD, intercuspal distance, box of CL2. Width of the cavity should be ICD. Figure 2. CL2 cavity preparation occlusal view. Removal of unsupported enamel by making the margin 900, -1100. Because less than 900 the tooth is more subjected to fracture. Fig 3. Smooth pulpal floor and gingival seat to prevent stress concentration. Area. 2. Mesial and distal walls of the cavity should be parallel and slightly diverge occlusally to be within the enamel rod direction and prevent any unsupported enamel at the marginal ridge. All internal line angle should be rounded to prevent stress concentration. Area. Fig 3. Box shape of CL2. Fig 2. Rounded gingival cavo-surface line angle. Cavo-surface line angle should be 900, 1100. Fasciolingual walls converge occlusally. Rounded. Internal line angle. Figure 3. Resistance factors which prevent fracture of the tooth. Preventing fracture of restoration, the margins or cavo-surface line angle should be 900, -1100. If more than this lead to fracture of restoration. Fasciolingual width should be ICD because large surface area exposed to more force and fracture occur. Occlusal amalgam should have thickness of 1.52.0 mm to resist fracture during function. 3. The pulpal floor and gingival seat should be smooth to prevent concentration. Area on restoration. Rounded axiopulpal line angle. Step 3. Retention form is the shape of the cavity that permits the restoration to resist displacement through the tipping or lifting force. To provide retention, the cavity have the following. Facial and lingual walls should be parallel to each other or converge occlusally. 50. Fig 3. Pulpal floor and gingival seat of the cavity should be flat. Dovetail preparation to increase retention. Fig 4. Width of the cavity. The occlusal convergence of the box from proximal view, Fig. 5. Retentive grooves, or locks in the axiofacial and axiolingual line. Angle Fig. 5. Incorrect. Dovetail. Preparation. Correct dovetail. Preparation. Retentive. Grooves. Position. Fig. 4 dovetail Fig. 5. Proximal view of Cli box. 4. Step 4. Convenience form. Convenience form is the shape or form of the preparation that provides for adequate observation, accessibility, and ease of operation in preparing and restoring the tooth. Step 5. Removal of remaining caries. Deep dentinal caries can be removed by using spoon excavator or large round burr with slow speed hand piece. Step 6. Finishing enamel walls. Involve making the wall smooth and removing of unsupported enamel. Step 7. Clean the preparation. Removal of all debris by washing the cavity and drying it. Clinically, occlusal outline form, occlusal step. The occlusal outline form of CL2 tooth preparation for amalgam is similar to that for CLI tooth preparation. Enter the pit nearest the involved proximal surface with a punch cut using number 245 per Fig. 6a. The long axis of the burr and the long axis of tooth crown should remain parallel during cutting procedures. The burr should be rotating when applied to the tooth and should not stop rotating until removed. Proper depth of the initial entry cut is 1.52 millimeters, while maintaining the same depth and burr orientation. Move the burr to extend the outline to include the central groove and the opposite pit. Fig. 5. 6b, which provided by dovetail retention form the isthmus width should be as narrow as possible and no wider than ICD. It may be necessary to tilt the burr to create facial, lingual slight occlusal convergence and mesial and distal walls to diverge occlusally. ABC. Figure 6. A. Initial depth. B. Burr position to begin the proximal ditch cut. C. CLI cavity preparation. Proximal outline form. Proximal box preparation. The objectives for extension of proximal margins are to include all caries, faults, or existing restorative material, remove unsupported enamel, establish not more than 0.5 millimeters clearance with the adjacent proximal surface facially, lingually, and gingivally. The initial procedure in preparing the outline form of the proximal box is the isolation of the proximal enamel by the proximal ditch cut. Fig. 7a. This is a very important procedure in conservative tooth preparation. Place the burr over the DJ and the pulpal floor near the remaining marginal ridge. Allow the end of the burr to cut the ditch gingivally, then move the burr facially and lingually along the DJ. This led to create axial wall. Fig 7b. The ditch should extended gingivally just beyond the caries. 6. The proximal contact area, the location of final proximal margins, facial, lingual, gingival, should be established with hand instruments, chisel, hatchets, gingival margin trimmers. Then remove the weakened enamel along the gingival wall by using the gingival margin trimmer and scraping motion. Ideally, the minimal clearance of the completed gingival margin with the adjacent tooth is 0.5 millimeters. Fig 7c. ABC. Fig 7a. The proximal ditch is extended gingivally to the desired level of the gingival wall, i.e. floor. B. Box formation. C. Clearance of the gingival wall with the adjacent teeth. A, B, C, D. Fig 8. The proximal ditch is extended gingivally to the desired level of the gingival wall, i.e. floor. B. Box formation. C. Clearance of the gingival wall with the adjacent teeth. D. Proximal view of the tooth. 7. Class V caries, smooth surface carious lesions located. Lex 6. Definition. Class V caries, smooth surface carious lesions located on the gingival cervical third of labial buccal and more rarely the lingual surfaces of all teeth. Simple lesion as it mostly involves one surface of a tooth as shown in Figure 1. Figure 1. CLV caries is not only the reason of cavitation, abrasion and erosion may also responsible erosion, tooth loss at the cervical area due to non-bacterial acid attack 1 abrasion. Tooth loss at the cervical area of the tooth due to abrasive slurry between two surfaces, mechanical action, for example, toothbrush, dentifrice abrasion. In both cases there is no caries. If we prepare a Class V cavity, it is better to be filled by amalgam, because of high abrasive resistance of amalgam. Restorative materials for Class V cavity: amalgam composite resin modified GIC compomers. Indications for amalgam as restorative material: non-aesthetic areas, areas where access and visibility are limited, areas where moisture control is difficult, areas those are significantly deep gingivally. Contraindications for amalgam as restorative material: aesthetically important areas. Advantages of amalgam as restorative material: amalgam restorations are stronger than other direct restorations, easier to place, less expensive to the patient. Usually easier to finish and polish. Two disadvantages of amalgam as restorative material. The primary disadvantage amalgam restorations are that they are metallic and non-aesthetic. The preparation for an amalgam restoration typically requires 90° cavo surface margins, specific and uniform axial depths, and incorporation of secondary retentive features, all of which results in a less conservative preparation than that for other aesthetic restorative materials. Clinical technique for Class V amalgam preparation. Initial clinical procedures: local anesthesia, isolation, rubber dam recommended. Tooth preparation. I outline form rounded trapezoid and gingival 1/3. Conforms to the tooth shape. Typical caries location and site of plaque accumulation, primarily determined by the location and size of the caries defect or old restorative material. Cavosurface margins should be extended to sound tooth structure while maintaining a limited axial depth of 0.5 mm inside the DEJ and 0.75 mm inside the cementum. When on the root surface, 3. Using round burr to start entry to the cavity. The direction of the burr should be perpendicular to the buccal, or palatal, surface of the tooth. Then using a tapered fissure burr of suitable size, enter the carious lesion to a limited initial axial depth of 0.5 mm inside the DEJ. This depth is usually 1 to 1.25 mm total axial depth, depending on the incisigingival-occlusigingival location. The enamel is considerably thicker occlusally and incisally than cervically. However, if the preparation is on the root surface, the axial depth is approximately 0.75 mm. Extend the preparation incisally, gingivally, mesially, and distally until the cavosurface margins are positioned in sound tooth structure, providing the desired outline form. Preparation of the axial wall depth 0.5 mm inside the DEJ results in a uniform depth for the entire preparation. Because the axial wall follows the mesiodistal and incisigingival-occlusigingival contours of the facial surface of the tooth, it will usually be convex in both directions as shown Figure 2. The mesial, distal, gingival, and incisal walls of the tooth preparation are perpendicular to the external tooth surface to keep the cavosurface angle 90° and to follow the direction of enamel rods. They usually diverge facially. Consequently, this form provides no inherent retention, and retention form must be provided for. Figure 2, convex axial wall 2. Resistance form depth of the cavity is 1.5 mm. The axial wall of the cavity should not be flat. If we do so, we'll not have even depth of the cavity because of convexity of tooth structure. So the axial wall should be slightly convex. Cavas line angle 90-110. Rounded internal line angles. Removal of unsupported enamel. Occlusal and gingival walls should be perpendicular to the long axis of the tooth and parallel to each other. Any convergence of these walls will create unsupported enamel. 3. Retention form. Use a number 1/4 burr to prepare 2 retention grooves, one along the incisoccal line angle and the other along the gingivoaxial line angle. Figure 3. 0.2 nil. 3 mm inside the DJ. The handpiece is positioned so that the number 1/4 burr is directed generally to bisect the angle formed at the junction of the axial wall and the incisal, occlusal or gingival wall. 5. Ideally the direction of the incisal, i.e., occlusal, groove is slightly more incisal, i.e., occlusal, than axial, and the direction of the gingival groove is slightly more gingival than axial. Mesial and distal walls should be slightly diverge. Figure 3. Retentive grooves of CLV3. Final preparation. Removal of any remaining infected dentin pulp. Protection. Finishing external walls. Cleaning and inspecting. Summary outline form. Rounded trapezoid. Axial depth 1 to 125 mm, when margins in enamel. 0.75 mm when margins are in cementum. Root surface axial wall 0.5 mm inside DJ, convex in all directions to conform the external tooth contour. 6. Divergent incisal, gingival, mesial and distal walls. Follow the direction of enamel rods. Retention features grooves and coves 0.2–0.3 mm inside DJ using 1/4 round burr. 7. like a cavity liner and cement base one. Ga. Liners and bases material act as pulp protection agents require consideration of chemical protection, electrical protection, thermal protection, pulpal medication, and mechanical protection, as in Figure 1. Reasons for use of base and lining materials. 1. Insulation against temperature changes and electrical stimuli under metallic restorations such as amalgam. 2. Mechanical protection provides by distributing local stresses from restoration across the underlying dentin surface. 3. To reduce the risk of microleakage. 4. Cementation of cast or ceramic restorations. 5. As a pulp capping. 6. Some have bactericidal or bacteriostatic properties. 7. Prevention of the risk of a long-term damage to the pulp dentin. Organ from operative treatment. 8. Cementation of orthodontic bands. The ideal lining material should have these properties. 1. Be compatible with the restorative materials. 2. It should not irritant to the pulp. 3. Prevent injuries of the pulp dentin from restorative materials. 4. Be insoluble in the oral fluids. 5. Possess sufficient physical strength during insertion of the restoration. 6. Prevent heat-cold conduction from metallic restorations. 7. It should have a bacteriostatic effect. Zinc oxide eugenol. 8. It should improve the marginal seal and have sealing ability. Zinc oxide eugenol, so we use it as a temporary restorative material. 1. 9. It should be easy to manipulation and apply. 10. It should be radiopaque in the X-ray. 2 groups of pulp protection materials are available: varnishes and liners, cement bases. The materials may be used alone or in combination, depend on the extent and location of the preparation, the restoration material to be used. Liners are materials that are placed as thin coating or layer. Function. 1. To provide a barrier against chemical irritation. They do not function as thermal isolators. 2. Reduce marginal leakage around most filling materials, amalgam, so reduce the inflammatory reaction and postoperative sensitivity caused by marginal leakage. 3. Electrical insulation, treatment of galvanic shock. The need for liners is greatest with metallic restorations that are not well bonded to tooth structure. Varnish, Ca-O2, and resin bond. Bases. Cement bases, typically 1 to 2 mm. Deep parts in the dentin should be covered by a base or a sub-base-base combination. The thickness of the base depends on its physical properties, but always allowing adequate thickness for the final restorative material. Function 1. Provide thermal insulation. 2. Mechanical protection by resist forces applied during condensation of the restorative materials. 3. A barrier against chemical irritation. 2. The cement materials include 1. Zinc phosphate cement. It is hard and strong but irritating to the pulp. It is a powder liquid system. The powder consists mainly of zinc oxide with the addition of magnesium oxide and silicon dioxide. The liquid consists of orthophosphoric acid, 40%, with metallic salts that serve to slow down the setting reaction, and water. Setting reaction. When the powder is brought into contact with the liquid to begin the cement mix, wetting occurs and chemical reaction is initiated. The surface of the powder is dissolved by the liquid, resulting in an exothermic reaction. The initial mixture is highly acidic, exothermic, ZNO plus 2H3PO Fa reaction ZNH2PO4 2 plus H2O plus heat plus ZNO. Zinc oxide plus phosphoric acid heat unreacted. Amorphous zinc phosphate plus zinc oxide plus. Advantages: 1. Easy to manipulate. 2. High strength necessary for a base. 3. Withstand mechanical trauma. 4. Provide good protection against thermal shock. Uses: 1. As a base material when high compressive strength is required. 2. Dilute cast restorations to the teeth. 3. Cementation of orthodontic bands. 4. Rarely may be used as a temporary cement dressing. 3. Fig. 1 schematic view of needs for pulpal protection below metallic restoration. Varnishes, liners, and door bases may be added to tooth preparation under amalgam for purposes of chemical, electrical, thermal, or mechanical protection and/or pulpal medication. ABC. Fig. 2 schematic examples of use of liners and bases for amalgam restorations. A. For shallow amalgam tooth preparations, varnish or sealer is applied to walls of preparation before insertion of restoration. B. For moderate depth tooth preparations, liners may be placed for thermal protection and pulpal medication. Note seats and sound dentin for amalgam restoration. C. In very deep preparation, calcium hydroxide is placed in deepest region in which infected dentin was excavated. and then base of glass ionomer is inserted. Amalgam bonding systems are being advocated as a substitute for liner and varnish, except for calcium hydroxide liner in the deepest region, judged to be within 0.5 mm of pulp. 4. Characteristic properties of zinc phosphate. 1. Consistency. 2 arbitrary consistencies, either luting consistency or cement-based consistency. In luting consistency, less powder-liquid ratio is used in order to have creamy mix, which is used for cementation of crown and inlays, while in cement-based consistency, more powder-liquid ratio is used to have putty mix of zinc phosphate cement, which may be used as thermal insulator over a thin dentin and as high-strength base. 2. Viscosity. It depends on time and temperature of mixing, so mixing should be made on a cool glass slab to reduce the viscosity of mixing. 3. Setting time. It is time elapsed between the end of mixing and the beginning of setting. Setting time of zinc phosphate range from 2 to 8 minutes at 37 C, depending on the product and the mixing. Consistency. 4. Strength. Influenced by the initial powder and liquid composition, powder-liquid ratio, and the manner of mixing, and the handling of the cement during its placement. 5. Solubility. Greater resistance to solubility is obtained by increasing the powder-liquid ratio. 6. Dimensional stability. Zinc phosphate exhibits shrinkage on hardening. This shrinkage can be reduced by increasing powder-liquid ratio and with proper incorporating of powder with liquid during mixing. 7. Acidity. In early manipulation stage, the cement is highly acidic and this acidity reduced with time and become nearly neutral at 48 hours. 8. Thermal and electrical conductivity. Zinc phosphate is desirable to protect against thermal and electrical trauma to the pulp. 5. Manipulation of zinc phosphate. The proper amount of powder should be slowly incorporated into the liquid on a cool slab, approximately 21 oC, to attain the desired consistency of cement. 1. Mixing slab. Because the reaction between zinc oxide and phosphoric acid is exothermic reaction, the glass slab should be thick, cool, and clean. 2. Powder-liquid ratio. Because an increase in the ratio of powder to liquid generally provide more desirable properties, incorporation as much powder as possible to obtain a particular consistency. 3. Care of the liquid. When zinc phosphate cement liquid is exposed to a humid atmosphere, it will absorb water, whereas exposed to dry air, will lose water. Addition of water cause more rapid reaction result in shorting setting time, while loss of water from liquid will lengthen the setting time. So the cement liquid bottle should be kept tightly closed when not dispensing the material. 4. Mixing procedure. The powder should be divided into several small amounts as in figure 1, so that each may be separately drawn into the liquid and spatulated. The liquid is dispensed to another area on the slab. B. Mixing over a large area. The heat of the reaction is most effectively dissipated when the cement is mixed over a large area of the cooled slab. A long, narrow-bladed stainless steel spatula may be used to spread the cement across this large area, as in Figure 2. C. The zinc phosphate should be mixed to a thinner consistency for setting inlays or cementation of crowns. A thick mix or thick consistency, a putty-like mixture, is used when basing material is required. This will cause lowered initial acidity of the base material, less post-operative pain, and ease of placement. 6. D. Mixing time not more than 60 to 90 seconds. 15 for each increment. 5. Frozen slab method. In this method, a glass slab is cooled in a refrigerator at 6°C or a freeze at -10°C. A mix of cement is made on the cold slab by adding the powder until the correct consistency is reached. The advantages of the frozen slab method are an increase in the working time and shorter the setting time. This method has been advocated for cementation of bridges with multiple retainers, also for preparing base material for multiple cavities at the same visit, or 4. Cementation of orthodontic bands. 6. Insertion of the tooth structure should be dry. This will ensure better adhesion and a harder set. B. Small quantity of cement is rolled lightly into a ball between the thumb and the fourth finger, then picked up on the point of a probe and carried into the cavity, as in Figure 3. C. Then the cement shaped with appropriate instrument, either ash 49 on the pulpal floor of the cavity, or ash 6 to adapt the cement on the axial wall in Class 2 cavity. The instrument coated with the powder of the cement to prevent the cement from sticking to the instrument. The axiopulpal line angle is molded to a round angle with the same instrument. D. Small excavator is used to remove any excess from the retention grooves or pits, and from the cavity walls. Any trimming by burrs should be delayed for at least 10 minutes after insertion to avoid dislodgement. If need to do that, do it with sharp burrs operated at low speed and minimum pressure. Adequate space should be left for the restoration, otherwise it becomes weak, and fracture will occur due to thin restoration. No cement should be extending over any margins of the cavity and in the undercuts. 7. When there are 1 or 2 spots of caries on the pulpal floor, they should be removed by round burr, but without removing the sound dentin. Around these spots to gain flat pulpal floor, because this may cause pulp exposure. In this case, a base material is used in these deep parts to have flat pulpal floor. Figure 1. Cement powder divided into small increments on a thick glass slab. Figure 2. Mixing of zinc phosphate is done on a white area on a glass slab. 8. Figure 3. A mixed cement ball is carried by the tip of the probe into the cavity. 2 zinc oxide eugenol cements, Zoe. Powder. Zinc oxide with the addition of white rosin to reduce the brittleness of the set cement, and zinc acetate to improve the strength of the cement. Liquid. Eugenol with olive oil as a plasticizer. 2 compositional changes have been used to increase the strength of the cement for luting purposes. 1-methyl methacrylate polymer is added to the powder. 2 alumina, Al2O3, is added to the powder and ethoxybenzoic acid to the liquid. Setting reaction. Zinc oxide plus eugenol water, zinc eugenolate plus zinc oxide. Powder, liquid, unreacted. 1. The reaction is not exothermic. A cooled mixing slab is not required, and the presence of moisture is essential for setting to occur. 9. 2. There is no need to incorporate the powder in small increments. The bulk of powder is incorporated in the initial step, and then a series of smaller amounts is added until the mix is complete. 3. The average setting time is around 8 minutes. Properties. 1. Neutral in pH. 7. Can be safely used in moderately deep cavities without danger to pulp. 2. Has a sedative effect on the pulp so that we use it without any varnish or liner. 3. Radiopaque. 4. Excellent seal against leakage, so used as temporary restoration. Uses. 1. As temporary restorations. 2. The modified type used as a crown and bridge cementation and as a cement base. 3. As an endodontic sealer. Zinc oxide eugenol cement is unaccepted as base material under Composite restorations because it impaired the setting reaction. Polymerization of composite resin. 10. Cavity liner and cement base 2. 3 zinc polycarboxylate cement. Zinc polyacrylate cements, or zinc polycarboxylate, are supplied as a powder and a liquid, or as a powder that is mixed with water. The liquid is a water solution of polyacrylic acid, 32% to 42%. The cement powder is essentially zinc oxide and magnesium oxide. The cement powder that is mixed with water contains the zinc oxide particles, coated by 15% to 18% polyacrylic acid. Properties. 1 polycarboxylate cement is one of the dental cement systems which have chemical adhesion to enamel and dentin by the ability of the carboxylate groups in the cement molecule to chelate to calcium in enamel and dentin. To the large sizes of the polyacrylic acid molecule, which can't penetrate through dentinal tubules, make the cement low irritant to the pulp, so this cement is used as a base or for cementation with sensitive teeth. 3 short setting time, 2 to 6 minutes. 4. The cement is sensitive to disintegration and solubility more than zinc. Phosphate cement uses 1 as a eluting agent, 2 as a base material, 3 in orthodontics for cementation of bands. 1. Manipulation. 1. Powder-liquid ratio for the base consistency is 2 to 3 parts of powder to 1 part of liquid by weight. The powder-liquid ratio becomes 1.5/1 when using polycarboxylate cement as a eluting agent. 2. Dry and cool glass slab are used for mixing. The cooling slows the chemical reaction and thus provide longer working time. 3. The liquid should not be dispensed until just prior to the time of mixing, to avoid evaporation of water which cause increase in the viscosity and this will cause decrease in strength and higher solubility. 4. The mix should be completed within 30 to 40 seconds. 4. Glass ionomer cement. Glass ionomer cements are supplied as a powder and a liquid or may come as capsules. The powder is fluoroaluminosilicate glass. The liquid typically is a 47.5% solution of 2 L-polyacrylic acid and itaconic acid. Copolymer. Uses: 1 as a base material, 2 luting agent. 3 also can be used as filling material, especially of the modified types of glass ionomer cements, CLI, CL3, CLV. 4 Fischer sealants. Properties: 1. The compressive strength is greater than zinc phosphate cement. 2. Glass ionomer cements are very sensitive to contact with water during setting. The field must be isolated completely if glass ionomer is used as filling material once the cement has achieved its initial set, about 7-2 minutes. Coat the cement surface with a coating agent such as a varnish, because the complete setting reaction takes place in 24 hours. 3. Glass ionomer cement bond to tooth structure chemically by ionic interaction with calcium and or phosphate ions from the surface of the enamel or dentin. In addition, when the enamel surface is conditioned, etched with 37% phosphoric acid, the bond strength of glass ionomer cement become greater, because acid etching of enamel surface will produce microporosities on the etched surface that will improve the mechanical retention. 4. Glass ionomer cement release fluoride, so it has anti-karyogenic effect, bacteriostatic or bactericidal. Thus the cement can be used in patient with a high caries index. Classification of glass ionomer cement. The most practical classification of the glass ionomer cements is on there. Clinical usage into type I glass ionomer cements are the luting cements, characterized by low film thickness and rapid set. Type II glass ionomer cements are restorative cements, with subtypes into 2 types. Type II glass ionomer cements are aesthetic cements, available in both conventional and resin-modified presentations, and Type II glass ionomer cements are reinforced cement which are more wear-resistant. Type III glass ionomer cements are the lining cements. Type IV Fischer sealants, characterized by low viscosity and rapid set, and Type V used for orthodontic cementation. 3. 5 resin cements are thin versions of restorative resins, e.g., Calibra and Panavia resin. Cements consist of a resin matrix with inorganic fillers that are bonded to the matrix with monomers. The fillers are silica or glass particles, and the fillers level vary from 40% minus 80% by weights. The bonding of the cement to enamel be attained by the acid etch technique, then bonding agent is used to provide Mechanical adhesion of the cement to etched surface of the tooth. Polymerization of resin cement is achieved either by chemical reaction, self-cure, light activation, light cure, or both dual cure. The self-cured composite cement are typically two-phase system, base, and catalyst, while the light cure cement is a single component system. Properties: 1. Resin cements are insoluble in oral fluids. 2. Higher filler particles loading result in higher mechanical properties, strength and stiffness, and reduced polymerization shrinkage, and lower coefficient of thermal expansion. 3. In some products, fluoride is added to act as anticarcinogenic factor and reduce the resin cement sensitivities. Uses: 1. 2. As eluting material either for cast or for tooth-colored restorations such as aesthetic ceramic and laboratory-processed composite restoration. Also, resin cement with high filler range can be used as a base material. 4. Cavity liners. 1. Cavity varnishes. They are solutions of natural resins or synthetic resins dissolved in a solvent such as alcohol, chloroform, or acetone. The solvent evaporates, leaving a thin film on the cavity preparation. Functions: 1. It is placed on enamel and dentin walls to reduce the penetration of oral fluids around amalgam restoration. The cavity varnish inhibited microleakage during the first few weeks. After that, the varnish will dissolve by oral fluids and replaced by the corrosion products of the amalgam which form at the amalgam tooth interface. 2. Varnish is applied on dentin surfaces to minimize penetration of the acid from zinc phosphate cements by occluding the orifices of the dentinal tubules. 3. Reduce post-operative sensitivity. Properties: 1. Varnishes neither possess mechanical strength nor provides thermal insulation because of thin film thickness. 2. When glass ionomer cement is used as a base material, varnish should not be used as subbase because glass ionomer cement contains fluoride, and varnish prevents fluoride release and reaction with the tooth. Also, varnish prevents the chemical bonds between tooth and glass ionomer cement. 3. Varnish should not be used when the restoration is composite resin, because varnish inhibits polymerization reaction of composite resin material, so calcium hydroxide can be used under composite resin. 5. Manipulation. Varnish solutions are usually applied by means of a small, round piece of cotton. A thin layer is applied on the preparation, then gently dried with steam of air. A minimum of 2 thin layers should be applied as the Initial layer dries, it leaves small voids, so the second layer fills in the voids and produce a more continuous coating. Varnish solutions should be tightly capped immediately after use to minimize loss of solvent. Most varnishes are supplied with a separate bottle of a pure solvent. The solvent used to keep the varnish from becoming too thick, also used for removing varnish from external tooth surface. 2. Bonding agent. Generally, bonding agents are unfilled resins which are used for mechanical adhesion of the composite restoration to the conditioned enamel and dentin. The conditioning is achieved by using of 37% phosphoric acid for 15 to 60 seconds, then washing and dryness of the tooth. These bonding agents act as liner for the composite restorations, especially for shallow cavities, because they occlude the orifices of dentinal tubules and reduce post-operative sensitivities. Also, special bonding agents are introduced as amalgam bond, which can act as a liner for amalgam restorations by sealing the cavity against fluid flow and microleakage. 6. Cavity liner and cement base 3. C. Dot. 3 calcium hydroxide, KO2, usually referred as liner, intermediate base, or pulp capping agent. Examples: Calcipulp, Dicol, Hydrex. Calcium hydroxide supplied as a two-paste system. One is a base and the other is a catalyst. Properties: 1. The set material has an alkaline pH 9.211.7, which reduces The acidity of zinc phosphate when used as a sub-base material in deep cavities, to the antimicrobial action of calcium hydroxide makes this material useful in indirect pulp capping procedures. 3-calcium hydroxide stimulate the odontoblast cells for the formation of secondary dentin, stimulate the formation of dentinal bridge when it is put directly over exposed pulp tissue. So, calcium hydroxide is used for direct pulp capping. 4. Water is an important component for the setting reaction of calcium hydroxide-based liner manipulation. Equal lengths of the different colored pastes are dispensed on a paper pad and then mixed into a uniform color, homogeneous, and then applied by using of Dykel applicator. The setting time is short, about 1–2 minutes. Therefore, the mix should be done quickly and then applied on a dry dentin so flow freely and easily. Proper setting requires humidity. Place a moist cotton pellet at the opening of the cavity on top 1. of the newly placed cement for 30 seconds. Be sure that the cotton does not contact the cement. After 30 seconds, check the cement gently with the explorer to ensure that it cannot be penetrated. A resin has been added to calcium hydroxide to improve its properties, improve thermal and mechanical properties, reduce solubility, and the setting is performed by light curing. Light activated. Cement is less brittle and has a longer working duration. They are provided in syringe form, and a replacement nozzle allows them to be applied directly to the tooth. Calcium silicate-based cements, they have useful characteristics including being biocompatible, having sufficient mechanical qualities, setting, and sealing in wet and blood contaminated settings. Their primary drawbacks include a prolonged setting time, a lack of radiopacity, and difficulty in handling. 2. When submerged in body fluids, they can chemically precipitate a calcium phosphate apatite layer. These qualities have resulted in an increasing number of new therapeutic uses, including root apex restoration, pulp capping, and bridges for pulp regeneration, endodontic sealer. 1. Mineral trioxide aggregate, MTA. It is available in 2 colors, white and gray color. Gray color. It contains tricalcium silicate, dicalcium silicate, tricalcium aluminate, bismuth oxide, calcium sulfate, tetracalcium aluminiferrite. White color. It has same composition as that of gray color MTA except the lack of tetracalcium aluminiferrite. Consequently, It is white in color. pH of MTA is 12.5 when set, so it has biological and histological properties similar to calcium hydroxide. Setting time is 2 hours and 45 minutes. Contrast to KO2, it produces hard-setting non-resorbable surface. 3. It sets in a moist environment, hydrophilic in nature. Indications of MTA? Manipulation of MTA? To prepare MTA, a small amount of liquid and powder are mixed to putty. Consistency. Since MTA mixture is a loose granular aggregate, it does not stick very well to any instrument. It cannot be carried out in cavity with normal cement carrier, and thus has to be tried with amalgam carrier or especially designed carrier map system. Once MTA is placed, it is compacted with burnishers and micropluggers. 2. Biotin. A dental cement available in the form of capsule containing the ideal ratio of powder and liquid with a rapid setting calcium silicate basis. This cement has 4. Relatively quick setting time, around 12 minutes. This is not achievable in MTA. That reaches setting time of about 3-4H, with better biologic handling and physical properties, superior sealing property than MTA. 3. Theracal LC. It is a resin-modified calcium silicate cement used as direct or indirect pulp, capping agent and as a protective liner under composite, amalgam, and cements, and other base material. The material's ease of handling may make it particularly appealing to physicians when compared to Dicel. It is a light cure material, therefore it may cause heat generation. Also, it comes in a one-paste system and have an instant high car release for short term, while Dicel has an instant low car release for long term. Unique benefits. Calcium release stimulates hydroxyapatite in secondary dentin. Bridge formation. Alkaline pH promotes healing and appetite formation. Significant calcium release leads to protective seal. Moisture tolerant and radiopaque, can be placed under restorative materials and cements. 5. General clinical consideration. After cavity preparation, certain factors should be taken in consideration during lining placement in the cavity. 1. The prepared cavity should be clean and dry before application of lining material. The quadrant of the prepared tooth should be isolated completely from saliva, because the entire lining and base material are sensitive to water during their application and setting. 2. All liners and base materials undergo dissolution and disintegration in saliva with time. Therefore, they should not reach to the margins of the cavity except varnishes and bonding agent. So lining is placed on pulpal floor in CLI, pulpal floor N, axial wall in CL2, axial wall in CL3, IV, and V3 in cavities prepared for amalgam restorations. The base material should not be extended on the walls of the cavity because this material will block the undercut's convergence of the buccal and lingual walls, which are important for the amalgam retention. Also, 6. All the retentive holes, grooves, and pins should be free from lining before amalgam placement. Cavities can be classified according to their proximity from the pulp into one shallow cavity preparation. As in fig bellow, there is no need for pulpal protection. There is a sufficient thickness of dentin so that no protective base required. For dental amalgam, the cavity is coated with 2 thin coats of a varnish or amalgam bond and restored. For a composite, the cavity is etched, coated with a single coat of a bonding agent and restored. Both varnish and the bonding system provide chemical protection to moderately deep cavity, as in fig bellow, a prepared cavity that extends into dentin beyond the minimal depth necessary to attain retention and strength for the restorative material. Varnish is used to coat the floor and walls, then a cement base, such as zinc phosphate cement or modified Zoe cement may be contoured to replace the missing dentine. 7. 3 deep cavity, as in fig bellow, that includes some extension toward the pulp. A liner such as Ka. 2 should be applied on the pulpal and axial walls. On top, a cement base is placed such as zinc phosphate cement or modified zinc oxide eugenol cement or polycarboxylate cement. Then a varnish is used to coat the walls. Recently, new protocol prefers the use of Dickel with glass ionomer base because of the presence of chemical bonding between the tooth and the glass ionomer cement that will reduce microleakage and the sensitivity postoperatively. Glass ionomer, calcium hydroxide. 8. 4 deep cavity with exposure of the pulp. Exposure of a small area of the pulp with no sign or symptoms of degenerating pulp. The choice of conservation pulp capping is recommended. In an isolated clean field, calcium hydroxide is carefully placed over the pulp and the border of dentin which surround the exposure site. A base material is placed on top, such as zinc phosphate or reinforced zinc oxide eugenol and also glass ionomer cement. Base is preferred. The restoration of the tooth should be completed as soon as possible. Secondary dentin barrier is likely to be formed within a few weeks.